What a great number of people that we have here today with us. I am so excited. This is fantastic. So Cindy Wade, I am the president here at LincolnHealth. And if you've not been in this beautiful building before, we are very proud of this building, and we just finished the front. That has been, yes. Your mom left me a very nice message. So I was just, Roberta Watson was a proponent of us making sure we put on so that people could drop their loved ones off without getting soaked, hopefully getting into their appointment, because as you all know, parking's a little bit of a challenge here on this campus. So sometimes you have to park quite a ways away. So. And we've been doing this for many years, and during COVID, of course, went virtual, and are excited that we have it in person, and are trying to revamp it a little bit, and thanks to the philanthropy team for doing that, because that's been something they've been excited about doing. We do have some people online, so virtually, which is an option, and I guess some housekeeping is please help yourself to food and water and coffees. There's bathrooms are out this door and to your left. If you have a question, please don't hesitate to ask. Those of you that are online, just use your raise hand button, and we've got somebody monitoring if anybody's got any questions online, so that's what we'd like you to do. I'd like to thank our team, done a great job pulling this together, making sure we had spots for people to park, making sure there was food, and hooking up with LCTV, which I also would like to thank LCTV teams here. And they are actually live streaming the community committee. This is something new for us so that others can watch it and it can be available on LCTV. We feel like there's some great information to be shared, and if we're sharing it, we should connect up with our partners at LCTV and make sure that's out for the community. So thank you for them being here and supporting us all the time with many, many initiatives, which you'll hear a bit about at the end of the meeting. So the meeting, I'm going to talk a little bit about the MaineHealth rebrand effort that's happening. And then I'm going to hand off to Dr. Fox, who is going to talk about where to go for care. Emergency room, urgent care, walk-in care, primary care, there's all kinds of care that you can receive, and he's going to talk about that. And then we have a list of updates, depending upon time at the end, that we'd like to give, one of which is Waldoboro building status. We're building a new facility in Waldoboro. So that's an exciting project we want you to know about. So maybe a couple other things as time allows. So any questions to start off? Nope? Okay. All right, so we got MaineHealth rebrand. Excellent, next slide. So I'm going to talk a little bit about why are we rebranding as a system, the MaineHealth system. I'm going to talk a little bit about what is actually changing with that rebrand, and then what that new look, you'll see some slides about what it looks like, and what our commitment is to quality care. It may be a different name, but it's still the high quality, safe access to care that you've always gotten. So here's the why a little bit, and sorry if that's a little bit of an eye chart for folks, but MaineHealth, Mal's laughing at me. So we've been part of the MaineHealth system for a really, really long time. And there's many of us throughout Maine that are part of the MaineHealth system. And there was a study done a few years ago that showed that even though MaineHealth has been around for a couple decades, it really isn't well known. And as we've come together and unified as a system to provide access to care in all of our local communities, it's gotten complicated, and we want people to know when they access a point of care anywhere in the MaineHealth system that what they can expect is high quality, safe patient care with experienced providers and care team members. So wherever you go for that care, we want you to know that. So in order to do that, we felt like we needed to kind of pull a thread through to make sure that you knew, regardless if you're in Sanford, Maine, you're in Rockland, Maine, you're in Lincoln County, you're getting the same high quality care in any of those places because we're all part of the MaineHealth system. So a couple of things, hopefully it'll be easier to understand and navigate because everything will now say MaineHealth, or it will in the future. I'll give a little timeline on that. Hopefully it'll make people understand that it's the same system, the same high quality, the same safe care, same access to care, same nice warm handoffs from place to place, the same Epic system for your electronic medical record. Again, easier access, and that communication hopefully will be simplified as we unify under one rebrand. The care team, it makes it a little bit easier for them as well. It gets confusing to figure out who you're talking to and what part of the system. If we're all talking about MaineHealth, it'll just look like we're all united. So, and our vision is working together so our communities are the healthiest in America. And by becoming one name, that will help us to elevate that. So that's kind of the why we're shifting to a master rebrand. So when I talk about the soup of all different brands, which are very near and dear to all of our hearts, right? It's a little bit of a mourning process for some of us, letting go of the birds and the waves of our logos. They'll still be near and dear to our hearts. I'm sure those logos will pop up as always everywhere until this gets really streamlined. But if you see that system, all those different logos, it's hard really to know who you're dealing with until you put it over there and we all start out with the same logo, the same name, MaineHealth. So all of this is moving to that. And I'll tell you a little bit more about that. And actually the southern part of the MaineHealth system, so Maine Medical Center and Southern Maine Medical Center, have now become MaineHealth entities, and it's MaineHealth Medical Center in Portland and Sanford and Biddeford. So that was the first wave as Maine Medical Center and Southern Maine Medical Center came together as one hospital organization and one license to provide care. And so that rollout is now coming up the coast and into the mountain region of the MaineHealth system. I don't want to keep looking back there, so I brought these purposefully. So what's changing? The logo, the colors, the fonts, all the fun stuff behind the scenes. There's lists and lists and lists, and we just had a presentation to our whole leadership team at LincolnHealth because there's a lot of behind the scenes things that'll change. You'll see MaineHealth on your bills. You'll see MaineHealth logo now, the new logo on your bills. All of our signage will eventually change. And it's really shaping the care of the future that MaineHealth is going to provide, bringing us all together, again, for that vision of working together so our communities are the healthiest in America. We're hoping that it is bold, it stands out, it reminds people that it's a breadth of care across the system. And if you can't get that care locally, that we're going to connect you somewhere else in the system or wherever you need to go, and it's going to be a warm handoff with the same logo, with the same brand, with the same care across the system wherever you need it. So, next slide. So just a little bit more about us. The yellow depicts the coastal region, because we're also working in regions in the MaineHealth system, and LincolnHealth is part of the coastal region, along with Midcoast Parkview Health, Penn Bay, and Waldo in Belfast. But you can see at the top here, that's LincolnHealth. So Lincoln Hospital, sorry. So yeah, it's gonna take a while. It's still miles really in my brain. It filters in all the time. So we will be MaineHealth Lincoln Hospital. So we dropped the LincolnHealth, the health part of Lincoln. It'll be Lincoln Hospital. All of the hospitals within the MaineHealth system will be a name and a hospital. So Penn Bay will be Penn Bay Hospital. Waldo will be Waldo Hospital instead of Waldo County General Hospital, Waldo Hospital. Midcoast Parkview Health will be Midcoast Hospital. So those are some of the big things that you'll start hearing in the fall when we go live with our rebrand here locally at LincolnHealth, Lincoln Hospital. Next slide. So here's a little bit about how that will work with some of the names. And this is really new to all of us too, as you already heard me say, trying to say Lincoln Hospital, LincolnHealth. We're going to keep our campus names. So again, the history of who we are and where we've been is super important to all of us. And so we really really wanted to make sure we could keep the Miles name and the St. Andrews name. So we will have a Miles campus and a St. Andrews campus. We refer to them that way today because we're Lincoln Health Miles campus, Lincoln Health St. Andrews campus. So we do that today, and we wanted to keep that. So that was a kind of a win for us locally. Not that Maine Health doesn't want us all to win as a system, but it highlights the fact that history is important, and the nomenclature is also very important to us. You can see as a hospital, we'll be Maine Health Lincoln Hospital, and I talked a little bit about how those names will work for other parts of our region. Our practices. So it gets really confusing to figure out what we're talking about when we say Lincoln Medical Partners. And then we have to say Lincoln Medical Partners Watson Center, Lincoln Medical Partners Watson Center, Damerscott. So, and then there's Waldoboro and Wiscasset and Boothbay, and then you start spreading that across the entire Maine Health system. It gets really confusing to people that just want to know, where do I go for my primary care? Where do I go to see my orthopedic doctor? So practices will be, and these are just examples, it's not inclusive of everything, but Maine Health Primary Care Damerscott, this building you're in. If somebody answers the phone, it'll be Maine Health Primary Care Damerscott in this building, in the primary care offices. Maine Health Primary Care Orthopedics Damerscott. So hopefully what it does, it makes it more clear who you're talking to and where you're going for care. Because people don't all know, especially new people to the area, what the Watson Center is or what Lincoln Medical Partners is. That said, this building, for instance, will keep its Roberta and Herbert Watson Health Center name, because that's legacy, and it's legacy from donors and work that went into this building. The same will happen, I probably jumped down already, for the John F. Andrews Health Center on the Maine Health St. Andrews campus. That's the building that Dr. Alamo works in, Dr. Hunold now works in. That's legacy. They'll still answer the phone, Maine Health, Primary Care, Boothbay Harbor, but it will still be also referred to as the John F. Andrews Health Center, because that is important to the legacy and the history of the organization. And the therapy center up on the hill, the new one, they'll answer the phone that they're Maine Health Physical Therapy Damerscott, but that building will still be referred to the Webster Van Winkle Health Center, because again, legacy work that donors have participated in, making sure we can have those facilities. So very important to the history of who we are. And then, so just going back up, for instance, if you were calling our infusion center, they would answer Maine Health Lincoln Hospital Cancer Care and IV Therapy. Infusion center sometimes doesn't make a lot of sense to people. And everybody across the Maine Health system will now use the same nomenclature. It would be Maine Health, Penn Bay Hospital, Cancer Care, and IV Therapy. And you can input whatever hospital it is you're calling, and that's how people will be referred to. That's how signage will look. So it'll make it simple for folks to understand. Another example up there is Maine Health Urgent Care St. Andrews Campus. So that's what you'll start to hear. Our rollout is not until September, but we're already starting to see this logo and the Maine Health name much more prominent, especially since the southern region has gone live with this. Next slide. So here's just some examples of things that'll start to look different. My name tag here. As you can see, Jane, the RN there, Maine Medical Center, NICU. Instead of Lincoln Health, Maine Health at the top with our current bird and waves, mine will look like that, except for it will say Lincoln Hospital, president or administration or whatever the underneath will be. I don't know what it'll be. And then signage will start to change, and you see, for instance, Maine Health Urology, Maine Health Emergency with the descriptor name, and other things you'll start to see, and different colors that will come along with it. And so a different look, but it'll be consistent wherever you are for Maine Health. Next slide. Our very own Andy Russ. He's on vacation, so he's not with us today, but So everything will start to look the same, whether it's a news release, it's something you see in the newspaper for an article, it's brochures, it's a pamphlet. All of those things will start to be bright. Our websites will all start to look the same. And any material, my business cards, if I go to business after hours and put my card in the bucket so I can win the prize, it'll look the same as anybody else's in Maine Health except for with my name. And you'll start to see these pictures were done purposely so we can start to show and highlight people that people recognize in local areas. You're used to seeing Lincoln Health. You'll now see Maine Health Lincoln Hospital. And it talks a little bit about the why. And so that you'll start to see more of that as we get closer to September for Lincoln Hospital. Already happened again in the southern region. And then the mountain region is also later this summer. What questions, thoughts? Yes?
The sign by the end of the road, will that change because it's so drab? You can sign
It will. So you're right. It's funny you say that. I was driving the other day and I'm like, gosh, it does sort of blend in. And I don't know if it's because we're all so used to it and it would be interesting, but it does blend in. The big H will stay as for the hospital sign, which needs to be there. But it will be Maine Health with the Maine Health logo, Lincoln Hospital on there. And then, so I skipped by it and I apologize for that because it's super important. So this is not rolling to our senior living facilities yet. That will be later in the year. So you will still see a sign out front for Cove's Edge, Schooner Cove, and Chase Point because they are still going to be those names. Not because we don't want to change them to Maine Health, and they are part of Maine Health, except for Schooner Cove is its own association. But just the bandwidth to make this happen, and so took the chunk of clinical care first, and then we'll move towards those. And really, we want to preserve those names as well. St. Andrews Village, Chase Point, Cove's Edge, those historical names. But you'll have more descriptors so people know you're really looking for a long-term care facility, a skilled facility, an assisted living facility. So we'll start using that eventually, but more than we have in the past. Yes, ma'am?
Walk-in clinic. How is that going to be?
This one here
Yes.
would be, somebody yell at me if I get it wrong. So Maine Health, Lincoln Hospital, yes, because it's part of the, no, that's part of the medical group. Nope, Marva. I'm having a hard enough time. Maine Health, walk-in clinic, Damerscotta. Urgent care would be, uh-oh, look at that. John?
Cindy?
John?
Hi, how are you?
Good, how are you? It's like God talking to me.
I'm not attempting to correct you.
Yes, you are.
It will be Maine Health. I believe they're going to call it walk-in care.
Did I say? I said clinic.
And
Takes a village.
Use, like when they answer the phone,
Yeah.
they'll use the Damerscotta issue.
Right.
Damerscotta geography there. There will be times where they're not using geolocation because if it's the only one in the market, then they won't always use the geolocation. There are longer names that will be used in some situations, but for the public, they're going to try to streamline it as much as possible to keep the names short.
Awesome, thanks, John. That's John Martin's our communication person. Thank you for keeping me straight. We'll get it right, but I think hopefully you're getting the gist of how we're shifting. I got a question in the back, and then we'll come to Mel.
Yeah, which discussion kind of illustrates the point I want to make. It's still very complicated.
Oh my gosh.
I applaud you for doing an umbrella name. I think that's great. But this place is, I've heard 4 names for this place. Damerscotta, Lincoln, Miles, and Maine Health. It's still really confusing. It's got to be simplified going forward.
Right.
It takes time. I suggest you get rid of the legacy stuff. That's nice. It's warm. It's heartfelt. But it really is no longer applicable to what you're doing here.
It is a behemoth. It is huge. It really, really is. And we'll get there, I think. It'll get more streamlined. It's going to be complicated. As you heard me stumbling over some of the questions, how to say the name correctly. Thank goodness we've got John in the wherever atmosphere he is. And so we'll get it pulled together. But you're right. I mean, you're right in that it's complicated, and we don't want to make it complicated. We want to make it more simple. So here's the first step in that direction. Signage, I think, will help too, because all of our wayfinding signage will have to be updated. It's going to be a work in progress. It's not going to pull back the curtains and it's all pretty and perfect. It's going to take us some time. So thank you for that, and bear with us. Mal.
You described a unified branding. To what extent will this also result in a unified system? And is the same cost going to be applied to the same service in each location? And is
He's testing me this morning.
the insurance environment going to be a system-wide one for all negotiations that happen between the industry and the hospital, or is it going to be fractioned still?
So that's like several meetings of discussion. So let me just try to hit some highlights, and what we can do is, somebody's taking notes, we'll bring some of that back for more deeper discussion, because I think, yeah, care is super important, and Maine Health was formed, and one of the first things we started doing is looking at standardized care and best practice across the system. So that is something we've been working on for many, many, many years, and is top of our radar. So patient-centered care, access to care, quality of care, safe care, best practice, evidence-based, all those things are things we've been striving for many, many, many years. And we continue to. And the way we're doing it is, so Lincoln Hospital can't do things that Maine Medical Center does, right? But what we're trying to do in our region, where we have like-size hospitals, is collaborate together so that we know that that kind of care that we give in local rural areas is streamlined and consistent and standard and best practice. So that is always a goal of ours. As we march forward, we get better and better and better and better at that. Insurance companies, that could be a whole discussion in itself. So we negotiate today through our Maine Health Accountable Care Organization and our finance teams with insurance companies as a whole. So my insurance, if you come here for Anthem, we have the same Anthem contract as Maine Medical Center, as Penn Bay does, as Midcoast does. So that's been happening for many years. So we contract as a system, which is actually helpful because it leverages the system, which is important. There was another one pricing. Oh gosh, again, if I could wave a magic wand, that would happen, right? Because if you were trying to open up access for colonoscopies, for instance, in our region, our coastal region, and we've been working really closely with Midcoast Hospital, and Jess is in the back, and she's front and center with this work, because Midcoast is way behind. They have this backlog, and we're churning and doing lots of colonoscopies here and have time and opportunity and space to do more. So we want those patients to come here if they want to, because they can get in sooner for their colonoscopy, but we're more expensive. So that's a problem, right? Because if you ask me, oh great, I can get in earlier. I can get in 2 weeks instead of 7 months for my colonoscopy because the doctor said I really needed to get one. Oh really? It's going to be more expensive? So that's hard, right? And we're all one system. That is on the radar. We're hoping to be able to pilot some changes with colonoscopies for our coastal region. We're working on that. In 2 years, we're hoping to be much further along with having one price for everything, no matter where you go for that care. It's going to be huge because of, sure, you could take a charge master and you could start from scratch and build one for the entire system, but then you got to bring in the insurance carriers. And then that's going to be a whole nother level of discussion and negotiation. And
your cost to deliver the same service is not going to be the same.
It can't be, right? It absolutely won't be.
How do you keep sanity in this system in terms of, both how you make your decisions and how patients make theirs? And even things like the uncertainty about price. I had a procedure done to my wife, and not that I had her do that, she had one. And the bill came back with price for the service, and then because it was going to be covered by the insurer, it was a differential, but it was a positive differential. It upped the price.
You must not have come here.
And when I commented to the finance people, it became, well, if you're going to pay it, just pay the listed price in cash. Oh, no, it went from 200 to 300, which was the differential.
Yeah.
So
It's complicated. I think if you do.
So bringing all of this melange of elements that fit together, and so that part of your task is to make sure that it's clear to the patients about cost, about explaining your situation where you can't bring it down to a simple, this is the price for the service kind of thing.
It's very complicated. We can put pieces of that into future meetings. It's hard to cover all of it, and it would be an all-day, well, no, probably longer than that. It's taken me 30 years to figure it out. But we can bring pieces of that back, so that's a good point. Yeah, very important. Any questions about rebranding? All right, because there's, Dr. Fox. You want to hear from Dr. Fox, and he's going to talk about where to access care and all that good stuff. So I think I need to give you this.
Morning, everybody. Thank you for coming. So nice to see familiar faces in the crowd. Dr. Tippy, Tracy Tippy, he is on PTO and on a plane right now, so I'm pinch hitting for him. So be kind.
PTO is vacation time.
Oh, sorry, vacation time. Sorry. So he's on a plane right now. So Revan had asked me to come speak with you guys about where to access care, and we live in a country, in a community that's lucky enough to have multiple options to access care, but that can lead to a lot of confusion. So she asked me to come here to go through some of those options. There's a handout that some of you guys have already that mirrors this talk pretty well. So if you want to reference that later, that's fine. So you can go to the next slide. So why is it important that you access care in the right environment? So there's a couple of reasons. It can save you time. In some instances, it can save you money. And a lot of times, the biggest reason, it gets you to the right resources at the right time. So there are certain diagnoses that we see. I'm an emergency physician, and there are diagnoses that we see in the ER that are very time sensitive. So things like chest pain that could be a heart attack, or stroke symptoms. Those are all time sensitive. You can see the icon up in the top right is time is brain, the time is brain icon. So the longer you have your stroke symptoms, the less well you are going to do without treatment. So it's very important to access the right emergency level of care. And it also, getting to the right place allows you to have continuity of care. So because we're all connected, as Cindy was just talking about, the main health system's all interconnected. You can go to an urgent care, like a freestanding urgent care in Brunswick or Bath, to your records.
Speak up, please.
They won't have access to your records at those institutions, nor will we have access to those records when you come back. At an urgent care outside of our system, we don't know what happened. We don't know what they prescribed. We don't know, what discussions they had with you. So it makes it more difficult. So continuity of care is another important reason that it matters where you go. Next slide, please. You can see we have a lot of options here. each level of care has different levels of resources, and they also have different levels of cost associated with them. So if you start out, if you go next slide, please. Start out with your primary care doctor, and that's your best option for things like your chronic medical conditions, vaccinations, annual physical exams, and that's going to be the most cost-effective option for you. So if it's not an emergency issue or something that you need to be seen that day for, that is always your best option. And it's very common when I'm working like a night shift or something, or even a day shift, patients call and they look for advice. Usually in the ER, what do I do? I have chest pain, or I have do, and the standard answer is that we can't give medical advice over the phone. And then have you called your primary care doctor? And that's the reason they ask you that, is because it's usually the best place to access care if it's a non-emergent issue or non-urgent issue. Benefits, as I said, is the cost. You can schedule your visit, so it means less waiting usually than if you go to the ER. Some ERs, we're lucky in this state, we see people from Connecticut who sit in an ER waiting room in Connecticut for 4 to 6 hours waiting to be seen, and they've told me that they can drive up here, be seen, and go home before they're seen. So the benefit of going to your doctor's office is that you don't have to endure long waits, hopefully. It allows for more acute settings like the emergency room to be able to see more acute complaints. So if the ER is inundated with people that are coming to just get their blood pressure checked, that puts those people with emergent conditions down the line. So that's another benefit. Next slide, please. So the limitations, obviously, hours of operation. We're not a 24/7 operation when it comes to primary care yet. So we'll talk to the primary care doctors about doing that next. And they have limited access to certain tests. So you can't just walk in and expect to get a CAT scan for appendicitis while you're seeing your primary care doctor. And it's also not appropriate for emergency conditions. Am I speaking loud enough? Okay. No? Oh, sorry. So yeah, so the second option would be the next tier up would be virtual care, and this is a newer one for a lot of people. So you can have a telehealth visit with your doctor or with another main health provider over telehealth, and these are good for things, as you would expect. These are good for things that you don't need to have hands-on evaluation. You can't push on someone's belly and see where they're tender over a screen. But you can look at a minor rash or talk to somebody that they're having, burning with urination or something like that. And those are good applications for virtual care. And we do have access to that. So it's very convenient for people. They could do it from their home, and it's efficient. They don't have to get in their car. They don't have to drive here, and they could be seen in a timely fashion. The limitations, though, not everybody. Yes, sir.
I'm wondering why it's more expensive than a doctor's visit.
That's a good question. Yeah,
The whole point of virtual care is it should be less expensive.
That's a really good question, and that's actually a question I hadn't thought of. And they put those little dollar signs up there, and dollar signs and $3 signs. I don't know if it's $5 or $500, but it's a really good question. Do you know the answer to that? Yeah. The answer would be, it has something to do with the technology involved, but that we're kind of evolving, and that stuff is kind of cheaper now. So it's
Why is there a facilities fee added to your urgent care fee?
virtual care.
Virtual care,
Well, you have to. There's still providers sitting at a place. Yeah. So
a large amount, sometimes as much as the actual
in person.
So
Yeah. Okay.
that's probably extra dollar sign.
The extra dollar. Yeah.
Facilities.
That's a good question, because we don't do virtual urgent care locally.
Well, no, it wasn't urgent care. It was a regular.
Oh, regular.
Yeah. No, she misspoke and said urgent care first.
All right.
Facility fee
Put that on the list of limitations then. So facility should be in quotes, I guess. So yeah, not everybody has, you take it for granted that we all have internet access or access to a laptop, but not everybody has that. So that's also a limitation. And there's ways that we can work around that as well with certain grants and things like that. Next slide, please. As we head up the kind of the hierarchy of care here, the walk-in care, as Cindy was mentioning, we have a walk-in clinic upstairs now, and they are open 7 days a week from, I believe, 7 to 5 when they're not maxed out, and they've been pretty busy. We've been open for only a couple of months now, and they've been very busy. The walk-in clinic is good for minor injuries, cuts requiring stitches, sprains, etc. Now they have a little bit more resources than their primary care doctor would. They can send you for an X-ray more quickly, get things more diagnostics more quickly, but they're not for more serious conditions. So if you go to the next slide. The benefits of them is the availability. So we have, in our system anyway, we have 4 or 5 walk-in care locations. Ours is one of the newest ones. The cost of walk-in care is also a benefit over an ER or an urgent care. Same $3 signs as telehealth, so I don't know if we do a head-to-head comparison on the cost there. Again, you have increased resources. Limitations, hours of operation, again, not a 24/7 operation. We close at 5 o'clock or 6 o'clock, so it's not possible for us to staff that 24/7 at the moment. And then there's limited ability to evaluate complex complaints. So you're not going to go there if you're, have multiple medical problems and you have a vague complaint like, oh, I just don't feel right, I'm dizzy. Something like that. That's going to require more time and effort. And you can't really treat as many issues as you could treat at an urgent care or an ER. So if you need IV fluids for dehydration, that's going to be tough to do in a walk-in setting. Next slide. So then if you take another step up into the urgent care world, you can see we added a $4 sign there, so it is more expensive. But it is good for more emergent conditions, or urgent conditions, I should say, like an asthma attack where you're not severely short of breath. Again, cuts that require stitches. They do have more resources. If you go to the benefits slide, more resources in terms of diagnostics. So you can get an X-ray more timely. You can get more blood work, urinalysis, that kind of stuff right there while you're waiting, which adds to the efficiency. There are only 2 urgent cares in our entire main health system, and that is the one in Booth Bay and one down in next to Main Med by Brighton First Care. And Brighton First Care is it's urgent care plus, they call it, and that's more of it functions more like an ER. We don't take ambulances. We don't accept ambulances at the urgent care. We will transfer somebody out by ambulance, but we don't take ambulances in. And I believe at Brighton, I think they do take ambulances. So it's a kind of a higher level of care there. They can do more complex things. They have access to CT scan and ultrasound. So if you need a CAT scan or an ultrasound, you're going to be transferred for that. So there's a potential cost savings for urgent cares. And they have a greater ability to treat illnesses like dehydration. Couldn't get that in a walk-in setting or in your doctor's office. Ultrasound in Booth Bay, and if you require an overnight admission, so if you show up at an urgent care and you need IV fluids for dehydration, but you're not really improving, and it looks like you're going to need to be admitted to a hospital overnight, you need to be transferred. And if you have a complex problem that you're presenting with that needs CAT scans and things, again, you'll have to be transferred. And that brings up the issue of transport. So patients will show up to the urgent care by private car, and then they're told they need a CT scan for their possible appendicitis. And then the options at that point is, do you go by your private vehicle, or are you put in an ambulance for $900 or something like that? So it really comes down to how sick the patient is and the recommendation of the provider that's seeing you. So if they think you're too sick to go by private car and they're worried that you're going to stop at McDonald's on the way to get your CAT scan, then they might recommend an ambulance. But if they think you're stable enough to go by private car, then that's always an option. So if they think you have a fracture that needs to be seen by an orthopedic surgeon, you don't need an ambulance for that. If it's just a broken wrist or something, you could be splinted and sent up by private car. And again, it's not a 24-hour operation. There are some states that have 24-hour urgent cares. We don't have any in the state that I know of. And then the top of the food chain here is the emergency department. It's also the most expensive option. That is good for pretty much anything. You can pretty much present to any main health ED or any ER with any complaint, and they will figure it out or try to figure it out. And they can treat it, or they can get you to the right place that you need to be treated. Good for things like shortness of breath, chest pain, stroke symptoms, mental health crises that involve suicidality or homicidality. So we see the broad spectrum of everything in the emergency department. Next slide. Obviously, the availability, I always joke that ER doctors are we've heard of hospitalists, like Dr. Smith is a retired hospitalist, and we call ourselves availabilists in the ER because we're always there and we're always available to see you for your problems. We have access to almost all specialists. If we don't have that specialist here, we have those across the system that we have access to. And we have access to almost all testing. So we can get day and week, we could get you an MRI. We could get, if it's an emergency indication, blood work and pretty much anything you need. And then another benefit is if the majority of our patients that need to be admitted, we can admit upstairs at the hospital as opposed to ambulance ride. So. And then the limitations, obviously the alluded to earlier, like you could show up and, if you don't have an emergent complaint, you may sit and wait for a little bit. It's uncommon here to wait more than, at the worst of times, more than an hour to be seen. It's very uncommon. We typically see people in 20 minutes or less, but crowding is an issue at all ERs. As is boarding an issue. So we tend to board patients more now than we used to because there's no room at any other hospitals, and sometimes even at our hospital, to admit you upstairs or get you transferred. So that those patients can sometimes sit in ERs for days waiting for beds. So you show up at the ER level of care when you only needed your primary care doctor or an urgent care. You could wait for a really long time to be seen, or you could bump the next person that needs. These kind of conversations are important. And then another limitation is Lincoln Hospital. We don't have. They're only at Maine Medical Center. So if you have a problem that requires brain surgery, you got to go by ambulance to Maine Med. And then some tests have limited availability. We used to have 24/7 ultrasound. There's no hospital that I know of that has 24/7 ultrasound. You to Maine Med at 2 in the morning, I think they'd probably make you wait till the next day to get your ultrasound. There is some limited availability. Next slide. So really, there's a thing called the prudent layperson standard, and that's part of a law that was enacted to protect patients from making that wrong decision. So, yeah, your chest pain may turn out to be heartburn, but your insurance company is not allowed, based on the prudent layperson standard, is not allowed to deny you payment or assist with the payment on an emergency visit just because it turned out to be heartburn. They have to base it on the symptom, not the diagnosis. So it's all part of the Emergency Medical Treatment and Labor Act, which is EMTALA. So we have to treat everybody regardless of their ability to pay, and the prudent layperson standard is part of that act. So I don't know if I have anything else on there. Any questions? No questions? Yeah.
Just out of curiosity, you hear stories of people that just go to the emergency room and never pay, and that's their first stop because they don't have a primary physician. They say you're stupid to do anything but go to the emergency room and not pay.
Yeah.
Do we have that problem here?
Yeah, we do. Yeah, we do. I mean, we see it all. So we'll see a patient take an ambulance from the outer limits of Waldoboro, get to the ED, and tell us that they just called the ambulance because they needed a ride to Damariscotta. And then they just check themselves out against medical advice, or they leave without being seen. So that does happen, and that's the most extreme example. But Cindy can tell you about there's a line item in all of when we look at the finances of the hospital called free care, and that's where a lot of that's the bucket all that falls into. And I don't know what we delivered in free care for 2023, but it was.
Here's our annual report.
Yeah. The annual, yeah, it's if you look in the annual report, it's in there. Yeah, several million.
Free care every year.
Yeah.
I just want to respond that for those of you, and many of you here were involved prior to main care expansion, Medicaid expansion in the state, where it was much larger. Right? I'm looking at Cindy.
Yes.
Wayne's not here,
Yes.
but
Yep.
I mean, there was a period of 7 years where we had people who were single, childless adults who had no coverage. Main care runs at 138% of the federal poverty level, but it took out nearly 90,000 people out of the pool of insured people. And I remember as a trustee here, every month Wayne would give us this forecast and the hole was getting bigger. I mean, we're talking 7 years. And 6.5 years ago, main care expansion passed. There are currently over 90,000 people now insured, which isn't, there's still people, I see them in my community down in the Booth Bay region, who can't get any insurance coverage, but it's better.
It is better.
Right? It is better. I shudder to think if we ever go back to cutting people out of insurance again. And the other real thing, maybe this community conversation sometime, should have Jeff Slack come talk about care partners, because he has magic wands and he just does incredible things. I mean, I've had catastrophic health situations, cancer, asthma, and he's been able to just pull things. Inhalers are very expensive for that, and he does it, and it's a real asset to our community. I don't think everybody has. Not everybody has a job. If it's not main care, then you have care partners, which also, and then there's the people who just aren't going to fit, right? And those represent, Mark is looking at the number.
2.3 million.
2.3 million, yeah.
For 23. Yeah.
Right.
That's probably, there's difference between free care and charity care. So it's a great point, Holly. And then I would say that people that have high deductibles, that's another category of people. Meeting a $10,000 deductible, that out of pocket is impossible for some people. So that falls into some of those categories. But care expansion certainly has helped.
And care partners.
And care partners over the years
Went
come
up $1 million.
periodically.
Look at that one.
It's tough to look at 2.3 million, but when you think
Well, there's a line in here that says on top of the 2.3. So.
Wow. It's really tough that we live in a country where. But that's a whole different conversation.
Yes, sir.
I had a recent opportunity to test out the same-day care system. Being a retiree out of the healthcare field, I was really interested in seeing how this model worked here. So, first point I wanted to share is that the information on this slide is very much in practice with the staff so I came in as a walk-in instead of the other choices. And they were very genuine and sincere to check and see at various times that I was satisfied still with essentially my own choice by way of, I thought, my injury was. So we worked very collegially, frankly, the three of us. And the second thing is, they had quicker access, I don't know, than my primary care providers do, through the record keeping. Perhaps it was just all skill. But the point is, even looking back on diagnostic work, I took a fall, that was the reason why I was there. So the x-ray history was there, and so on and so forth. And we just made a common decision about completing the service there and going home.
Yeah. That sounds like that was the objective, right?
That was my objective.
Yeah. Yeah. Well, thanks. Thanks for sharing that. Anybody else? All right. Thank you.
Great. So my name is Brooks Betts. I'm just going to give you a real brief update on the Waldoboro project that we're working on for a new practice building similar to the one you're in here. So going back to what Mal talked about in the rebranding, for those of you who don't know, we have two practices for MaineHealth that are in the Waldoboro community. Both are in buildings that are rented, and they're very difficult buildings for us to keep up to standards. And so several years ago, MaineHealth, as part of our coming together, talked about taking those two practices and joining them and building a new building in the Waldoboro community. So many of you who've been to this meeting before have heard more about it, and we can come back and talk to you more about it as we go. But Stacy, Cindy, myself, and others were on a call this morning at 7 a.m. getting just kind of the project update from the steering committee level. And so it's really exciting. You can go to the next slide. And I don't have a whole lot of illustrations to show you today, but I want to just give you something to look at. So we have a property up on off of the main town, right up behind the town office on Depot Road at 126 Depot Road. There's a piece of property up there which used to be Fieldcrest Nursing Home that was up there, and that closed probably 12 or 13 years ago anyways. We at one point owned that, sold it, and we actually recently bought it back. And we also bought another piece of property that's adjacent to it to help us kind of fill out what this property is going to be. But this is just kind of the footprint of what the building is going to look like on that property. They actually, I think next week we'll be putting up the fencing to actually start the work on the building. The first thing that has to happen with the Fieldcrest building is we have to get the asbestos out of it. The building had asbestos all over in it, so it needs to be abated completely before you can demolish the building that's there. We're starting with a clean canvas here, so that building, and anybody who's ever been around that building or knows of that building knows that it's in dire need of being demolished and a new facility being built there. So the one really cool thing about this, though, is that we're working with the town of Waldoboro as well. The town of Waldoboro actually got a congressional directed spending grant of $1 million to help with infrastructure for this, as well as their ability to use this property. And what we're looking at is we'll have this section here, but there'll be a section here where the town will actually be able to put a rec center in there. And the goal is that we'll be able to share things like parking lots, share the cost of some of the infrastructure of electricity and those things coming into that facility. So I don't have a rendering today, and I'll tell you why is because you can go to the next slide. So the building started out, I think originally we were looking to be around 16,000 square feet as in total. But because of the cost of construction and what we had budgeted, we've had to what we call value engineer the size of the building down. And I think it's okay, like, because when you first put pen to paper and you start looking at this type of thing, people have grand dreams of what they want to have, and we were talking about having a rehab gym there and things of that nature, which just reality is once you realize the cost of doing that, we're just not going to be able to do that with this building. But for the ability to bring these practices together, which was what our ultimate goal was, is that we are going to be able to do that in this 14,000 footprint. I also don't have a rendering of the building right now. I tried to get one this morning, but I think there's a couple questions as to, in that value engineering, exactly what the exterior of the building is going to look like. We've been trying to utilize the land, the placement of the building on the property to maximize minimize the cost of groundwork that would have to happen, because that's also very expensive. So the project is kicking off. As I said, the fencing will start going up next week. They will, if not in July, by August, they will start the asbestos abatement. The demolition will probably happen in the month of August, maybe into September. And then I think in earnest, you really see, we've still got some hurdles we've got to get through with the town and the DEP and others before the actual construction starts. My guess is you're not going to really see that. We might actually do some earthwork probably in this calendar year, but a lion's share of the actual work on the building wouldn't happen until next year. Construction, once we started actually doing the earthwork, we're probably about a year away from having the building complete. So we're probably looking at fall of next year would be when that building would be complete and ready for us to move in. I'll come back with more updates as we have them. It's just, this is a great opportunity to have our community here and talk about it. I mean, when we talk about coming together, rebranding, working together, and then looking at a community like Waldoboro, that's been a heavily underserved population for a very long time, and it's a very, very large community when you start talking about all of the peninsulas that go down. So it's a great opportunity. We've done a really good job in Booth Bay. We've done a great job here, and so Waldoboro is our next, and even in Wiscasset, we've got a good practice there, but Waldoboro is our really next big opportunity. And so this is a long time coming, but also something we're very excited about. So, questions? Yeah, go ahead.
Besides bringing those two buildings together,
Yep.
Are there going to be expanded services, like more doctors that are available to see patients, not just as far as the facility goes, but just actual visits?
So, I believe so. I mean, I believe that the planning in the volume is that we will be because we're bringing all the providers together. So the one thing that's nice about that is that you'll have better access to all of the providers of both those practices coming together. So you get some synergy anyways, because you have a vacant slot over here and a vacant slot over here. You're at least able to fill those up. If you had a person, you can swap people around. So I think we're going to get some efficiencies from that. I don't believe Stacy Miller would know better as to whether or not we're adding any providers to this. I don't think I've heard that. I think it's more that we're just bringing them together first. We are building in some growth into this building, though, even at the 14,000 square feet. So it should have the ability to take on more. And next question's back here.
Yeah, I want to say thank you first for coming to Waldoboro.
Oh yeah, right, exactly.
That's fantastic. And I'm wondering whether there might not be synergies between the community center that the town is thinking of placing near that site.
Yep.
Close to it.
Right, exactly. I know that's not that.
And
Yeah.
things you need, we can work together on.
Right, yeah, so I think one of the things that Julie Kaiser has been very involved with us all along the way, and I think she's had some really great ideas of things that they could do in the community center that might be opportunities for us, whether we would be able to offer therapy services. And I see the YMCA represented back here. That's the other thing, is that with childcare in our community, there's so many opportunities, both behavioral health, positive health, like the YMCA. Childcare is another huge thing that our YMCA here in Damariscotta is working on and trying to support the Waldoboro community. So there are a lot of really great opportunities. And one of the things is an organization, Maine Health, is really, our mission is working together so our community is the healthiest in America. And the one thing about that is that it's really important that we're trying to be proactive with our communities, right? Not waiting for them to come to the doctor, but trying to meet them where they are. And so we've worked with the YMCA here locally on doing things where we're trying to help with diabetes education and, other things that we can do within our community to help people be more on the proactive side of their healthcare versus reactive. Yep, go ahead.
One of the issues Waldoboro is having is how to define its community center.
Yeah.
What the hell to build it for.
Yeah, right.
your input on that context will be very helpful to
Okay.
focus attention and prioritize needs. And I'm encouraged that you're being proactive about putting those things on the table. Thank you.
Great, thank you. Any other questions? Well, thank you. Oh, go ahead,
Just
Holly.
timeline? What's the timeline?
Oh, timeline. So yeah, as I said, we're going to be starting to do the asbestos abatement now. The actual demolition of the building will be probably in the August, September timeframe, and then probably a lot of groundwork will happen this calendar year. But my guess is, we may actually really break ground on the project, but we've got some hurdles with the town we've got to get through first. I mean, we're working with the town, so it shouldn't be an issue. They know it's coming, but we have to go through all the right avenues to make sure the planning board has an opportunity to see it, weigh in any concerns. We just really got all of the construction documents completed, so now we're at the point. But we do have bids, and we're at the point where we're really ready to start making that stuff happen. I just don't know whether the actual groundbreaking will happen this calendar year or whether it's going to bump into next year. Yeah, in weather, exactly. Yep. You have to work around that in Maine. Great. Any other questions? All right. Thank you so much, and I'll turn it over to Revan to give you a philanthropy update.
Thanks everyone for coming. My name is Revan Oliver. I'm the Director of Philanthropy here at Lincoln Health, and I'm going to keep it very brief because we're at our time at this point. First, I wanted to address Holly's point about Jeff Slack. A few weeks ago, we had Jeff speak down in Booth Bay, and it was recorded by LCTV, and they will be that show at some point. I don't know the date yet, but we'll be getting word out there. It was great. He was so that will be a good one to keep track of. This is our next a series that we're starting, and our own Jess Pinkham, who's in the back of the room here, she is going to be helping us host this one along with Dr. Reed Feller. They are going to take us behind the scenes of the OR and actually show some filming of an actual cataract surgery that happened just a few weeks ago. So it's going to be absolutely fascinating. The idea behind this talk is to demystify the OR, kind of take some of the scariness out of it. So really excited about that. And I also wanted to throw it out there, if anyone has ideas of to talk about in this meeting, we would love to hear it. I do have one request to talk about artificial intelligence here at Lincoln Health, and we're working on that presentation. We definitely have something in mind. We're already talking to some of the surgeons that are indeed using AI in surgery here at Lincoln Health. So please let us know if you have any others. We'd love to hear them. The next meeting will be down in Booth Bay. We're going to have it at the Again, we will have a Teams meeting so that if you're not able to come down. And then the third one for this year will be here, again in this room in November. How we're doing and figure out how we're going to go forward in 2025. Please help yourself to some food. We have a lot of food. Otherwise, the ER is going to be getting a ton of food today.
What is the date of the next one? One in St. Andrews?